This is my presentation on fluency disorders for the caregiver. First, we're going to go into the causes. There is currently no known cause for stuttering. Theories have been built on environmental, genetic, and neurophysiological observations. However, there is none that is universally accepted. Here are some of them that I have included. There's the cerebral dominance theory. According to this theory, people who stutter are less likely than their fluent peers to have developed what is called unilateral cerebral dominance, which is the typical tendency for one half of the brain to exercise more control over certain functions. So this theory would explain why some people who stutter are often ambidextrous. There's also the two-factor theory of stuttering, which views stuttering as involuntary disrupted speech resulting from negative emotions in the speaker. There's also the diagnosogenic theory, which states that individuals who exhibited normal stuttering in their childhood were misdiagnosed as a person who stutters. This misdiagnosis, according to this theory, is what provoked the abnormal stuttering tendencies in the individual. Then there's the demands and capacities model. In this model, each person is born with various levels of innate capacity to speak fluently. Some people have less of this fluency capacity than others, and this capability then interacts with the demands of the speaker's environment, and when these demands outweigh the speaker's capacity, stuttering may occur. Now, this is not so much a theory as it is a prevalence in the family that is viewed for stuttering. Familial prevalence is how often a particular condition appears in generations of blood relatives. So the familial prevalence of stuttering is higher than that in the general population, which leads researchers to theorize that if there is one person who stutters in a family, there are more likely to be more among his or her blood relatives. And it is also well documented that stuttering is far more common in boys than girls, with a ratio of 3:1. Just some speech characteristics now for stuttering. There are repetitions, which is saying the same element of speech more than once. So they could be part word, like Saturday, whole word repetitions, I could not do it. Phrase repetition, I am, okay. There can also be sound prolongations, where sounds are produced for a duration longer than what is typical, like mommy. And there are also silent prolongations, which are also called blocks, where there is no vocalization at all. Now, some secondary characteristics are interjections, which are extra unnecessary elements introduced into the speech sequence. So there can be sound or syllable interjections, like some word interjections, like, well, okay, phrase interjections, you know, I mean, and there are also broken words, where there's a space in between the word, like after, incomplete sentences. Last year we went to Paris, where they kind of just abandoned what they were saying originally. Revisions, which is changing in wording that do not change the overall meaning of the sentence. Circumlocutions, which is dancing around the word, where it seems like they're trying to avoid articulating a certain sound. And then some physical characteristics that are secondary are groping and tremor. So groping is clenching up the fist or grabbing onto parts of their bodies, which is usually in frustration, and tremors, which can be of the lips, of the legs, or other parts of their body. Now here's just some assessment approaches. So in order for the SLP, the speech language pathologist, to determine whether or not a person has a stutter, a detailed case history of the client must first be obtained. The following information will aid in the evaluation: the onset of stuttering and any circumstances possibly associated with the onset, the course of the stuttering after it first began, so its severity, its variability, and stability, how it presented after it first started, the familial prevalence, which I explained earlier, prior clinical services and treatment procedures, and if there were any effects of those procedures, current, past, or future education and occupation of the client, and the general health history. Now, the SLP may conduct an assessment of the frequency and types of disfluencies presented in the individual speech by recording an extended conversational speech sample with the clinician and/or member of the family, or an age-appropriate reading sample. The SLP may also ask to have the individual recorded in various environments, such as a school, in a home, out with friends, just to assess situational effects on speech. A rating scale may also be provided for the individual or the caregiver to provide information on their attitudes and their feelings about their speech in certain environments. And lastly, here are just some treatment methods. So it should be noted that none of these are proved to be effective alone. Usually they are used in conjunction with one another. So here we have the psychological method, which treats stuttering as something that is driven by the underlying theory that it's a psychological disorder. So this kind of treatment would really just involve a lot of counseling and discussion about how the speaker feels, their attitudes, their emotions towards their stutter. The fluent stuttering method is the stutter more fluently approach, which aids the speaker by modifying the severity of the stutter. It also attempts to aid the speaker in reducing the secondary characteristics of stuttering that are visible to the listeners. And the goal of this method is not necessarily to obtain normal fluency, but to reduce the abnormal stuttering that's presented in the speaker. So this kind of treatment would involve teaching, identifying the actual stutter, desensitizing the client to his or her stutter, modifying it, stabilizing the gains after treatment, and also counseling is involved as well. And the stutter modifications in this method are done through cancellations, which is pausing after a stuttered word and saying the word again with an easy and more relaxed stutter. Pull-outs, which is when you change stuttering in mid-course by slowing down and using soft articulation. And preparatory sets, which is before the stutter occurs and it's just to change the manner of it. Then there's fluency shaping. The goal of this type of treatment is similar to the fluent stuttering method in that it aims to stutter more fluently than to obtain normal fluency, and this is done through the teachings of appropriate airflow management to support sustaining speech, using easy phonation, being very gentle, and a reduced rate of speech. This method also introduces maintenance strategies not only for the speaker but for family and friends to monitor and reinforce fluency in natural settings and over time. The fluency reinforcement method. In this one, the clinician arranges a pleasant and relaxing therapeutic environment in which he or she will positively reinforce fluent speech with verbal praise and tokens. The clinician would frequently model a slow, relaxed speaking rate that assures stutter-free speech. Evidence suggests that fluency reinforcement may be effective with younger children. Um, Something to note, when a stuttering person hears his or her own speech with a fraction of a second's delay, most of their disfluencies are reduced. So this is the evidence backing up masking and delayed auditory feedback technique. So using this with a masking noise and treatment can improve fluency. In this technique, the SLP can use a machine that allows for client-specific modification regarding noise duration and variable delays. The delay is gradually faded to reshape fluency. Now, direct stuttering reduction method. This is a kind of stuttering treatment that seeks to reduce fluencies directly. Methods in this type of treatment include timeouts, in which the person who stutters is taught to pause after each disfluency, and response costs, where a token is removed after each disfluency. Of the two techniques, timeout is better researched, although evidence supporting response costs in treating young children is accumulating.